So management of complex heel pain. There's a lot of reasons why we get heel pain. And I think, if we look at heel pain broadly, it's something that we see in anywhere from, 30 to 40 up to potentially 50% of our biomechanical patients. Some research indicates that we're, really seeing quite a significant amount of heel pain within the podiatry clinic. We're going to go through a bit of diagnosis, management, when to treat surgically, and that surgical management as well. I want you to think of heel pain quite broadly. Plantar heel pain can be caused by a number of different concerns. Fracture, periosteal reaction, infection or tumours, neural nerve entrapment, radiculopathy, tear rupture, enthesopathy, heel pad atrophy, trigger points, tear and rupture, plantar fasciopathy, or plantar fasciitis. To get to this, how do we get to this diagnosis? One of my colleagues at UWA, Dr. Renee Sylvester, who I was just talking to the other night, last night actually, put this together a couple of years ago, and it's very in depth, and I hope you're not watching off a phone right now, so that you can really appreciate the yeses and nos that lead to what we're looking at as a diagnosis. Now, this is something that I'm happy to share with everyone as well, and I'll be putting the replays up of this video because I think it's really important to sort of appreciate where we're getting to our diagnosis and what other differential diagnoses could it be that we may not have thought of and maybe contributing to non-resolution of patient pain in those cases. When we're looking at plantar heel pain management, it's really based on that subjective history. A lot of us will say, within about 30 seconds of a patient coming in and saying, this is when I get pain, this is where it is, we straight away know that it's going to be plantar fasciopathy, which is the most common type of heel pain that we would all be seeing. However, when we then put that subjective history with our clinical findings, our diagnostic imaging, and then couple that along with our patient's ability and willingness to undertake specific interventions, it then becomes a bit difficult on how we actually manage this. Obviously, a lot of the time, patients want this fixed straight away, and without putting them into a boot with a steroid injection straight away, we can't necessarily resolve that pain quickly. Again, muscle fascia is going to take a certain amount of time to heal effectively. So what I do is I approach my patients, whether they're coming to me for an initial opinion or for a referral on from surgery, for surgery, I'll sort of have a bit of a chat to them about what their needs and expectations are around the consult. If I can get away with what I call a no shot, no surgery option, which is what we're doing as general podiatrists, including orthotics, exercises, laser therapy, plus or minus the use of a cam boot, reducing their activity, and again, that reassurance and education, then that's going to be, a big part of it. And if you're all able to undertake this quite effectively, then 90% of our patients with heel pain are not going to have any concerns. Again, 90% of our patients with heel pain are going to have symptom resolution within 18 months. And so it's about having that chat about that extra 10% of patients that are finding that this isn't resolving their pain, and whether we can then look at, our other options to strengthen that further. I then go forward from my conservative options or more conservative options into my injection therapies. And whether that's a ultrasound guided cortisone injection, a hydrodilation therapy, which I do a real lot of, particularly for neural concerns, as well as one of the things that I'm really enjoying at the moment is that amniotic fluid injection. And one of the local products is AmnioFix. And AmnioFix has growth factors, structural proteins, and immunomodulatory factors that act as a stem cell magnet to really increase that healing. And for me, although this is quite expensive, this is really looking at that potential outcome that can be equivalent to a surgical release or a plantar fasciotomy of the plantar fascia. In the right condition with the right symptoms, patients are going to have a really good outcome. And when I use the AmnioFix coupled with a moon boot for a period of 4 to 6 weeks, you're generally looking at that 90% resolution rate of those that are coming through to me that would otherwise have a plantar fascial release. When patients are not resolving from your care within the clinic, and they're getting to the point where it's really affecting their life and they're unable to manage that pain, that's when I would suggest coming through for an opinion. A lot of the time I will be undertaking MRIs of these patients to rule out other concerns such as space occupying cysts, including ganglions, but also our different accessory muscles as well, which can be causing a lot of our tarsal tunnel syndrome and causing a lot of neural involvement there. When we look at heel pain surgery, when that's indicated, a nice quick way to fix this is a plantar fasciotomy, and we generally do that of the medial band full release. That can be done through minimal incision and can be undertaken within the rooms for the right patient under local anaesthetic. We also then look at a plantar heel spur resection. We can see these photos up here that are really looking at our options, and this is the fluoroscopy just over here. And we're able to get this image that's showing that we're in line with that calcaneus, so that we're not actually puncturing into the calcaneus, but we're getting rid of what spur there may be there. That's generally a really good option to undertake if there is a spur, but as we know, the spur is not generally the problem, and it's usually that plantar fascia. And so that's a clinical decision that I make as to whether a plantar fasciotomy is okay as a single procedure, or whether we need to look at a heel spur resection as well. When we look at tarsal tunnel syndrome and the release around that, if that's a contributor, we're looking at that flexor retinaculum release. Generally, I'll do this open because although MRI is fantastic at this, there's been a number of cases where I've got into a tarsal tunnel, released the flexor retinaculum, and then I've had a cyst or an accessory muscle pop out at me that's then been released when we do that flexor retinaculum release. And in those cases, it may be that we do a minor debridement of that muscle and repair, or we need to excise that ganglion if that's the case. And these may be coming off the tendon, the muscle, or other structures in that area, such as joints. And yeah, as I mentioned, I like to undertake that open. Extraosseous talo-tarsal stabilisation. The device is called a Hyprocure, and I find this to be a fantastic procedure in a lot of patients, particularly that have flat feet. But a lot of patients that have heel pain, that have got knee, back pain, or bunions, as I mentioned earlier, can really benefit from this type of procedure. And what we're doing is we're changing that talo-tarsal alignment and really getting into that more appropriate position. What we're looking at is a device that's generally called an arthroaresis, and that's placed within the sinus tarsi of the subtalar joint. And these are x-rays that are showing that calcaneal declination angle or talar declination angle that's really been corrected when the use of a Hyprocure is implanted. What we're looking with this Hyprocure in particular is that's a little bit better than some of our other arthroaresis because it's really acting within our line of action within the subtalar joint. And for a bit more information, I'm actually going to get the creator to have a bit of a chat about that because it's absolutely fantastic, some of the things that he's doing here. So this is Michael Graham, who is a podiatrist and podiatric surgeon from America. And the Hyprocure is actually his baby. So I'm going to let him speak for a couple of minutes on that.
This is the calcaneus or the heel bone. There are 3 articular facets where the ankle bone or the talus sits on top of the heel bone. The back joint here is called the posterior facet, and the middle and anterior facets are on the front and inside of this bone. In between these 2 joints, we have a naturally occurring space that's called the sinus tarsi. You'll note that there is no cartilage that's found in this space. That's going to be very important. So This is the ankle bone, again, called the talus. The talus sits on top of the heel bone, and there are two complex motions that the talus goes through on the calcaneus. It is supination, which tightens up the foot structure, and pronation. So when the two bones are together, again, we have this nice open joint space that's called the sinus tarsi. Sinus means space, and tarsi is the hindfoot bones. So when the ankle bone goes through the normal motions, that sinus tarsi space should basically stay open no matter which foot motions are occurring, the supination or the pronation. Now, there's a medical condition where the talus partially slides off of the heel bone, and that creates an abnormal closure of the sinus tarsi space. And you can actually even see that there's a partial dislocation of the joint. The reason why this is important is that you have to imagine that the weight of the body above is resting on the top of the ankle bone, and that weight should be evenly distributed, passing through the back of the heel and then also passing through the front of the foot. When the ankle bone slides forward, there's an abnormal shift of forces. So what that means and why that's important is because the forces that should have been passing through the back of the heel are now passing through the front of the foot. And this will increase the strain to the tissues within the arch and the rest of the foot. Also, because of how that ankle bone slides off of the heel bone, then this creates an unstable foundation to the whole rest of the body. So this can affect your knees, hips, and back. So when we talk about this problem, this is something that you're never going to outgrow. So observation is really not a realistic treatment option, because with every step, we have the reloading of these forces, and until eventually some kind of symptom's going to happen in your foot, knee, hip, or back. Also, most of the patients that have this problem will never experience any pain or symptoms within their foot. The majority of symptoms are felt in their knees, hips, and back. Again, talking about treatment forms. So a lot of doctors will want to put an arch support on the bottom of the foot. The only problem with that, and it might sound like it makes sense, but it cannot stabilize and realign the ankle bone. With every step and while people are standing, this ankle bone is still displacing on the heel bone. So that's why we have Hyprocure. This is obviously a blown up model of Hyprocure, but Hyprocure is a titanium stent that is inserted through a minimally invasive procedure into the sinus tarsi space. So let me take this off. You'll see that Hyprocure sits in between the articular facets. So it's really important to know that it does not go into a joint. So once the Hyprocure stent is inserted into the space, we still have the natural range of motion occurring. So Hyprocure doesn't block the motion, it restores the motion. One of the great features about Hyprocure is that unlike traditional rear foot reconstructive surgery, the Hyprocure device can easily be removed. So it's a great reversible procedure.
Okay, so that really gives you a bit of an idea of what we're looking at there with the Hyprocure. I'm sure that raises a lot of questions about its potential application, and obviously being the creator of it, he will market it for everything. And that's everything from diabetic peripheral neuropathy, because it's going to increase the blood flow through the nerves because they're not stretched as much, right up through to talomandibular joint disease, because it's going to allow the first MTBJ to undertake the windlass mechanism more effectively. So take it all with a grain of salt, but you get the basic idea of the principles around what the Hyprocure is able to undertake and the correction that we can maintain there. And as mentioned, we're able to remove that if needed. And a lot of the time we're able to maintain that correction due to the more structurally sound ligament tendon forces in that area. So the applications are really for that flexible flat foot deformity. When we start to have, moderate to severe arthrosis of the subtalar joint, it's not going to be as effectively undertaken, and our outcomes start to decrease. This is for people who don't want to rely solely on their orthotics. I had a gentleman come through to me recently who was looking at it because orthotics didn't fit into his sporting shoes. We can also look at people that are getting pain in their foot, ankle, knee, or back that we think is related due to that talo-tarsal destabilisation and hypermobility. But as I mentioned earlier this evening, it can be used for those mild bunions or to aid with further bunion reduction that's undertaken as a primary procedure through metatarsal osteotomy.